This is QD Clinic. I'm Jack Cush with Room Now. QD Clinic is brought to you by Room Now Live. It's like a sharp edge that cuts through the clutter, meaning that the interactivity, the insight and delivery of our faculty really kind of clarifies a lot of clinical issues for those of you who will attend either on-site in Dallas or online. We'll see you at roomnow.live. Our case today is the hairdresser with a swollen joint. 31-year-old woman, she's a hairdresser. She presents with swelling in both wrists and a left ankle, so not just one joint. She says she's tried taking a leave twice a day, but really has received no benefit. She has no past medical history, never been to the doctor, and never been in the hospital. She's married. She's a hairdresser. She's monogamous. She went to Mexico about 3 months ago on a 2-week vacation. Nothing unusual happened there. Now she shows up with a few swollen joints in your office. She's got a temperature of 100. And her heart, lung, head, eyes, ears, nose, throat, all normal. No skin lesions. On a joint exam, she has synovitis, clear synovitis in one wrist more than another, and somewhat in the left ankle. There is no enthesopathy. There's no tenosynovitis. There's no nail changes. She has no scalp changes and no skin problems. Her white count is 9. Her SED rate is 56. Her CRP is elevated 2.1 milligrams per deciliter. She has negative tests for rheumatoid factor, CCP, ANA, Hep C, and Hep B. And the question is, what further evaluations would you like to see? When we asked, a lot of people are asking a lot of things, including B27 and Lyme titers and UAs and chest x-ray and Parvo B19, and you wouldn't do uric acid. This is a young woman. Gout's not a problem until you're a postmenopausal woman. The differential diagnosis, according to Cush and the Rheumanology card. If you don't know what the Rheumanology card is, go to rheumanology.com. On the top, click on RK card. It's a 2-sided card. It's got lots of diagnostic information on there. It's like a peripheral brain that you carry around when you're a resident. And the differential diagnosis of acute monoarthritis and acute oligoarthritis is number 1, gout. Number 2, septic. Number 3, viral. Number 4, pseudogout. Number 5, reactive arthritis. Those are the main considerations in acute. This is acute. Oligo or mono. Oligos and mono differential diagnosis is the same. Poly is very different, right? You could consider a fracture, bursitis, tendonitis. That doesn't apply here. What are the bugs that we could be looking at? GC, staph, strep, gram-negatives, Lyme, TB, or viral, Hep B, Hep C, EBV, rubella, Parvo B19. That kind of covers all the bases here. So what was done? What was done was a urine PCR and showed evidence that she had gonococcus. So she had no cervical symptoms. She had no urinary symptoms. She had no vaginal discharge. She had no skin symptoms and no sore throat. You had to suspect this on the basis of her being young and sexually active, and unfortunately not monogamous, because it turns out that she was the source of the infection and not the husband. And that, of course, would be a very sensitive discussion between you and your patient. So how can you distinguish between GC and gonococcus? GC and reactive arthritis? That would have been a strong consideration here. GC is more likely in women, reactive arthritis more likely in men. The GC duration is usually days, maybe a week, whereas reactive could be going on for weeks. Sore throat is a little bit more common. It could be due to the GC if oral sex was involved. Eye symptoms are much, much more common with reactive arthritis and not with gonococcal arthritis. Genital symptoms are more likely with reactive. Most people with gonococcal infections don't usually have genital symptoms, and it is actually more common in men than women. One of the telltale signs for me has always been tenosynovitis. really very common in GC and not so common in reactive arthritis. Or the finding of a cutaneous pustule. You should look hard for those because they can be seen in, some minority and should not be seen in minority of GC and should not be seen in patients with reactive arthritis. Again, the clues are age here. She's young enough that you should consider GC in the differential diagnosis. And it used to be that diagnosis was difficult because getting a GC to grow required prompt and quick collection and whatnot. But now with PCR, the nucleic acid specific test actually is much better and easier to make the diagnosis, and with great accuracy, by the way. The differential diagnosis here, aside from disseminated gonococcal infection, could be endocarditis, osteomyelitis, and other diagnoses associated with the arthritis, dermatitis presentation. Neat case, and this was one of my partner's case, and she made the diagnosis right away because she had her thinking hat on, and she knows how to handle these things. Hope you found it interesting. We'll see you at Room Now Live.